food. There's a metabolic function. It's a great storage organ for particularly glucose. Hematological function, it produces clotting factors. We've talked about storage function and detoxification as well. Almost all drugs, unless they're renally excreted, get metabolized through the liver. So it's hugely important from a physiology and pathological viewpoint. And when we think of LFTs, you guys will all know this, I'm sure, but LFTs are essentially just a range of serum indices that can be grouped according to the information that they provide. So I've listed the typical LFTs there. So we have these, some indices provide information about the synthetic function of the liver or how well it's working. So that includes prothrombin time, albumin, and actually bilirubin as well. Typically, it's not considered in textbooks, bilirubin, as part of the synthetic function marker, but it's really important for synthetic function as well. You've got the transaminases, so AST and ALT, which are enzymes that are housed within the hepatocytes. That's the main cell within the liver. And they give us information about whether there's any liver cell or hepatocyte disease, so parenchymal, that's relating to the organ disease. And then bilirubin crops up again because it's a really good indice of whether there's any disease of the biliary tracts, along with ALP, alkaline phosphatase. And we'll go through those in a little bit more detail. And like I say, please do chip in. I can't see the screen, so if you do just want to just butt in, please just use your microphone for the rest of it. And just if you want any further clarification about points or have any particular experience that you think might be beneficial. I've also put at the end here, others to be aware of, so that can help put into context what might be going on in somebody who has abnormal LFTs, and that's platelets, creatinine kinase, and gamma. And actually, as hepatologists, we check these as well, and they can be quite useful at picking apart some of the more complex patients, or if something's not particularly obvious on the initial screen. So it's really important. Look, as with any test, you just got to take it in the context of the patient's demographics, their history, any imaging that they have available, and also what medications they're on. Because as we'll see, medications are the commonest cause of why we, during the day, as hepatology registrars, are asked to review patients who have abnormal LFT. It's almost not always, but most of the time, more often than not, it's due to medications, and particularly common antibiotics such as coamoxiclav that can throw your LFTs off. So certain patterns of these indices can help differentiate between different liver diseases, and we'll talk about that in more detail. And again, when thinking about LFTs, the two things I think that it's really important to consider are the changes, and are what we're seeing on ICE acute, or are they chronic? And also, what's driving them? What's driving the abnormality? Do we know that yet? Because often what will happen is, we've all seen on call, you go and you chase LFTs and they're wildly off. And you think, does the parent team, or do I know why they're wildly off? And one of the things is a framework that can help to differentiate between the causes is a non-invasive liver screen. And if you guys are familiar or aren't familiar with that, we'll go through that at the end. Like I say, it's a nice framework that you can just in your head take a screenshot, or I can send this PowerPoint presentation out to you guys. And if you have it on a phone when you're going to see patients, it can just help to make sure that you've got an ordered appreciation and evaluation of the patients. So just to start with, going through a few of those things. So bilirubin, I think, is probably the most important from a hepatology point of view, LFT. Bilirubin itself is a breakdown product of red blood cells. The most important thing to appreciate, I think, about bilirubin is that it comes in, there are two forms in the body that are circulating at any one point. There's an unconjugated form, which is more akin to the breakdown, the initial breakdown product from red blood cells. And that unconjugated bilirubin travels to the liver, where it conjugates with this thing called glucuronic acid. And the conjugation basically just means that it can travel through the liver and get excreted because it becomes water soluble with the conjugation. And it can be excreted in bile, and then it goes through into feces or urine. Okay, It's that conjugation that makes it unconjugated to conjugated occurs in the liver, right? And when you're checking on ice and you bilirubin level, it's the total concentration of bilirubin. That's both unconjugated and conjugated bilirubin. And actually, sort of classic teaching says, and we really don't do this in particularly well in clinical practice. No one does this particularly well. But if the bilirubin is elevated on LFTs, typically what you should do is you should actually go back and you should say what part of this of the elevation is due to the unconjugated fraction and the conjugated fraction, and the labs will actually measure that for you. And for us, and that's called a split bilirubin level. Okay, so it's taking that total bilirubin level and it's saying what part is due to unconjugated versus conjugated forms. And so I'm just flicking between the two because I think sometimes the picture and this flow diagram helps, because if it's predominantly the conjugated form of bilirubin that's elevated on the indice, then it means that actually the disease pathway, I hope you can see the mouse that I'm moving during this as well. I'm not sure, but I'll carry on. It is due to likely, but if it's predominantly the unconjugated that's elevated and thus is driving the raised bilirubin level, it's actually due to a commonly not that related to the liver. And it can be due to hemolysis. That's the pathological breakdown of red blood cells, or the sort of accelerated breakdown of red blood cells that causes this huge spill out of unconjugated bilirubin into the bloodstream. And so it's important to check whether the patient is anemic at that point. But also there are a range of different congenital conditions. So genetic that can predispose people to having unconjugated hyperbilirubinemias. So that's an elevated level of this unconjugated bilirubin form, such as the commonest is probably a thing called Gilbert's. Like I say, as hepatologists, and it's good practice that if you've come on shift and it's really the first time that the LFTs have been checked and have demonstrated this raised bilirubin level, it's probably worth going to the clinical chemistry add-ons and asking them to do a split bilirubin level, because like I say, that will tell us whether this is and help to elucidate what might be going on, because it helps tell whether this is an issue with the conjugation, i.e. the liver disease or the biliary disease, or it's happening before that. And because I think bilirubin's the most important LFT, if the bilirubin is raised, for me, it's then just helpful to determine whether it's an isolated rise, whether it's elevated along with this other marker, alkaline phosphatase, that's also produced by the bile tracts, and thus, in that setting, suggests there's some biliary disease. Or if it's elevated, but actually proportionately, the transaminases, so the ALT and AST, so those enzymes produced by hepatocytes, are relatively higher than the bilirubin itself. And that suggests that actually what you're looking at is what we typically call like a hepatic picture of the LFTs. So that's bilirubin. And we can have a discussion about bilirubin afterwards, or any of this stuff if you guys want. So albumin is another important thing to look at when you look at it's part of the ICE LFT package, if you like. Albumin's produced in the liver, and historically the levels are considered to reflect the synthetic function of the liver, because really the liver is the only place that produces this protein albumin. So it's a bit like if the levels are low, it suggests that the liver's not being able to synthesize and produce as much albumin as it normally does, so maybe there's an impairment of the function of the liver. But the problem with that is that albumin's actually affected by loads of other things. So if you've got somebody who's septic or just unwell with SIRS, or they're not absorbing enough protein from their diet, so things like celiac disease and stuff, or If they are excreting too much albumin into their GI tract and pooing it out, and thus has nothing to do with the liver, the levels can be low as well. So actually, albumin's not particularly specific to saying if the albumin's low, then there must be a liver problem. But what I would say is that in somebody with known liver disease, it's a really good marker of how they are getting on. Okay, so if somebody has chronic liver disease and they have a low albumin, it tends to mean that their liver is not working well. And generally, I think I've put this thing at the bottom, this point at the bottom in italics and brackets, because there's no real evidence for this, but this is just, I think it's more anecdotal and talking to other colleagues about this, but albumin is just a really good marker of like how unwell someone is. So I think if the albumin's low and you've got somebody who's ill, then it tends to be that they're pretty ill. But like I say, there's nothing, I don't have any values, like if it was 5 points low or if it's 10 points low to enumerate or correlate that with. But it just guides you. So I think when it's all part of that assessment, and sometimes you go and see a patient and at the end of the bed you just go, they don't look great. And it's kind of a biochemical version of that. It's like if you look at the bloods, you've never seen the patient, but the albumin's like really low, you're like, there's something wrong here, they're not well. And that's about all there is to say about albumin. Prothrombin time. So this is part of that clotting screen that we typically do routinely on patients. So the PT, prothrombin time, is a measurement of how long it takes blood to clot, and suggests that it is the clotting cascade. I think we're talking about in a few weeks, quite complicated. We'll go through some pictures of it, but essentially the liver produces some clotting factors. There are loads of clotting factors, and the ones I've listed here are specifically produced by the liver. So if the liver is impaired, if the function of the liver is impaired, the liver can't produce to the same degree those clotting factors, which means that people have a propensity to clot less and bleed more, and that's reflected in a greater prothrombin time. So typically patients with acute liver failure or chronic liver failure have a raised prothrombin time. Prothrombin time can also be measured as an INR. So the INR is like a normalized ratio of the prothrombin time. So if you see prothrombin time or INR, it's basically the same measurement. It's just one is a normalized version of the other. So it's interesting, when I was just putting these slides together, I was doing some reading, and it suggests that actually you need quite a large loss of synthetic function. So the paper suggests more than 70% of synthetic function of the liver has to be impaired for there to be an increase in prothrombin time, which is quite significant. So it's not an early sign of liver disease, but actually if you see somebody with an increased prothrombin time and they have liver disease, again, it's quite a worrying sign. But again, it's important to remember, and that's the final point just there, that a prolonged prothrombin time, or INR, can indicate liver disease, but also a deficiency of vitamin K, because vitamin K is required for the liver to be able to normally synthesize those clotting factors that affect the prothrombin time. So vitamin K deficiency can happen irrespective of liver disease if you're not absorbing fat, if you have profound nutritional deficiency, or what we call chronic cholestasis, which is a chronically impaired biliary system and biliary drainage system. And so you might have seen that sometimes people have been given, or the prescribers among you may have been asked to prescribe vitamin K for some individuals with prolonged prothrombin times and liver disease, or who are jaundiced, or who are alcoholics. And the reason is that we give kilograms of vitamin K IV for 3 days to those individuals who have a raised prothrombin time and evidence of obstructive jaundice, or who are at risk of nutritional depletion of vitamin K, which we basically consider are all the alcoholics, chronic alcoholics. And the point about giving the vitamin K is it's saying that if the prolonged PT is due to a lack of vitamin K, you can give the vitamin K IV and it might help the prothrombin time to improve. But more often than not, particularly with the alcoholics, the prothrombin time, they might be nutritionally depleted, but the prothrombin time is actually due to the fact that their prolonged prothrombin time is actually due to the fact that they've got liver rather than the fact that they're vitamin K deficient. Alkaline phosphatase. Alkaline phosphatase is produced in the liver, particularly sort of around the bile ducts. It's also produced in the bone, the GI tract, kidneys, and white blood cells also produce a little bit of alkaline phosphatase. But I think it's really important to remember it's not just the liver, but also the bone that is a major site of ALP production. And therefore, if you have bone disease, you can get a raised ALP. So that's not just like metastatic bone disease, that's also bone fractures. So acute or chronic bone disease, you can get abnormal ALPs. But also if you have cholestatic liver disease, you can get a raised ALP. And so that's one of those situations where sometimes you might go and check some LFTs and there's mainly a rise in the alkaline phosphatase level. And the next thing to do is to make sure or to check what that means. And the way of doing that is to check to see whether this other measurement called gamma GT, which again you can add on, it's not part of the routine LFT indice package, but you can just ask chemistry to add on a GGT. And the GGT is only produced by the liver, and it tracks, the levels track the alkaline phosphatase levels. So if your alkaline phosphatase is elevated on the ICE lab results, and you want to know, oh, could this be due to bone pathology or pathology? If you also measure the gamma GT and see that that is elevated as well, then the ALP is due to liver disease, not bone disease. And the second point there is just to say that if there's any doubt, because sometimes you can get mixed pathologies, you can actually ask the labs to separate out the different isoenzymes of the alkaline phosphatase. And this can help differentiate hepatic from non-hepatic causes of raised alkaline phosphatases. ALP indicates, so ALP and bilirubin classically indicate this idea of biliary disease. Okay, and we're coming back to that in a bit. AST and ALT, we talked about these. These are the transaminases, the enzymes that are produced by hepatocytes or within hepatocytes. And when the levels are elevated on the LFT ICE indices, it suggests that there's hepatocyte death or injury. And I'd say, yeah, this is one of the most common abnormalities that we see. So ALT is more liver specific because it's mainly produced in the liver and not so produced at other tissues, within other tissues around the body, right? And that's why I think when you look at, when you order LFTs on ICE, they routinely add the ALT, but they don't have the AST on them as well. The AST is also really important to check. And but the AST is also produced in skeletal muscle, cardiac tissue and smooth muscle. And so it's important to be aware of that, because if you have a raised AST, it doesn't necessarily again mean that this is liver disease that you're dealing with. And I think, you know, when I was thinking about things, I think a thing that we also do quite poorly across the board is that we don't often think of other causes of raised transaminases. I think from a clinical and holistic point of view, one of the most important things to think about when the transaminases are raised is actually, yes, liver, but could this also be heart? And people who have had a myocardial infarction, because AST is produced within cardiac myocytes, would also have a raised AST. And so if you've got somebody who's had their blood indices checked, particularly over the weekend, when often routine bloods are just put out, for no apparent reason, or to chase up on people who've been acutely unwell, but we never really got to the bottom of it. And the patient's got really raised AST and ALT, but then you don't think they've got any evidence of any other LFT abnormalities or any liver disease. It's probably just also worth checking a creatinine kinase and doing an ECG and asking if they've had any chest pain, because you do occasionally see that although people think that this is a liver-related test, you know, we forget that it can be raised in other things such as MIs and such. And the graph at the bottom just shows that. And what you tend to get is this quite nice pattern of different tests that, you know, we're very used to thinking about troponins in the context of heart disease and acute myocardial infarctions. And they do rise within 6 hours, and there's the doubling effects and all the rest of it that we get very good at checking. But a few days after the onset of myocardial type chest pain, so angina, or really, we're talking about occlusion of the coronary arteries. So we're talking about an acute coronary syndrome here. If you look at the days after and you measure the blood levels of creatinine kinase, AST and LDH, you get this quite nice trending effect where they each have a peak a few days after. So from a transaminitis point of view, so that's AST and ALT, yes, we always think about liver, but it's also important just to remember that they are also produced in other tissues, and important to remember that people who have heart attacks get raised AST. And so if you don't think it's liver disease, or no one's considered it, or people are just routinely checking a person's bloods without really knowing what the pathology is, it's always worth just remembering to do an ECG and ask if the person's had any chest pain in the last few days. And so the last thing before we sort of try and tie some of these concepts together is to think about platelets. And platelets obviously are part of the routine full blood counts, but platelets give a really nice indication about whether somebody has advanced liver disease, because they go down. So in advanced liver disease, you get portal hypertension. As the liver becomes fibrotic and cirrhotic, that blood, rather than going through from the guts, traveling back to the heart through the liver, as the liver becomes cirrhotic and fibrotic, and the blood pressure is higher in the liver, it gets shunted. And as it gets shunted, you get this increased destruction of platelets, and they can sequester, so they can collect. That is, they can collect in the spleen as it enlarges in advanced liver disease as well. And so platelets are quite a nice way of telling whether something is acute or chronic when it comes to abnormal LFTs and liver disease. So I'm just having a swig of my tea. So in terms of patterns and important patterns of LFTs, so I think from what I've seen over the years, from a hepatology point of view, it tends to be that they fall into these three patterns. So you get these isolated raised bilirubins on blood tests, and for those patients, that's where you want to be measuring not only the total bilirubin that the ICE report will give you, but also looking at the split bilirubin level that tells us whether this is an unconjugated bilirubinemia that might be due to hemolysis, so the patient's anemic as well, or Gilbert's, which is this one of these congenital disorders of bilirubin conjugation, or whether it is a conjugated hyperbilirubinemia, in which case often the alkaline phosphatase is also raised, because that's an indication of cholestasis. So biliary disease, blocked bile ducts, whether that's stones, metastases, or medication can cause that. That's that cholestatic picture. And then in the middle there, we have this hepatic
We've lost
pattern.
Screen share, Hugo.
I've lost screen share.
We can't. Well, I can't see any slides that you're talking about at the moment.
Okay, when did that happen?
About the start of this section, we had a brief bit of here are the patterns, and then it's disappeared.
Is it back?
Not for me, I'm afraid.
Not for me, no.
I haven't got it. No, I haven't got it either.
Oh, there you go. Okay, it's just dropped off here, like that.
Yes, we're back.
Okay,
Yeah.
cool. So yeah, so I'll just talk through those patterns again. So I think over the years things mainly fall into these three important patterns where you get this isolated raised bilirubin, and in that instance we're checking the split bilirubin level to see whether this is unconjugated or conjugated, and that helps provide us information about where the pathology might be. A hepatic pattern of abnormal LFTs, which tends to be this raise in AST and ALT. So the predominant rise is in the transaminitises. And from a practice point, we often get called or asked on the ICE referral system to come and review patients urgently, particularly when things like or the ALT are 1,000 or over 1,000, and because high numbers are serious and they are concerning. But actually, from a practice point of view, there are only about 3 or 4 things that cause AST or ALT levels to be at that high level. Patients are septic and unwell, so they're hypotensive, and that can cause an ischemic hepatitis. They can have had drugs like paracetamol that's caused global parenchymal liver disease or liver death acutely, or they've got a viral hepatitis. So they're actually relatively straightforward to manage and investigate. And then you've also got this idea of a cholestatic pattern of LFTs, which is where you've got a predominantly raised bilirubin and alkaline phosphatase, and that indicates often that there's some sort of biliary disease, or they've taken medications to cause those abnormalities. And I think two important things with these patterns is when you're looking at the LFTs, it's what's the predominant rise. And there are different algorithms, and people say, oh, if it's 10 times above or if it's 2 times above and all this sort of stuff. I think it just comes down to thinking in a logical manner. Each indice has an upper range of normal, and how far above the upper range of normal is the abnormality across the different tests, and then grouping it into those different groups and saying, well, okay, so the bilirubin and the ALP, they are high, but actually relative to their upper limit of normal, they're only, say, doubled. But the AST and ALT are like 5 times above their upper limit of normal. And so actually, on balance, proportionately, it's more of a hepatic type pattern of abnormal LFTs. Because the nuts and bolts are is that when the liver's ill, everything can be up. So, and there are different boxes, and I think, one of the things that's quite useful is just to order it. So these are the typical liver abnormalities that you might see if you're looking at people who have acute or chronic hepatocellular, so parenchymal liver disease, or people who have cholestatic liver disease. And I can send these ones out. You can take pictures of them. I think there was quite one of the, when I was training, Geeky Medics used to do Geeky Medics is a website or a sort of whole series of things that inform trainees how to interpret tests. And Geeky Medics probably have some quite good stuff on here. This is taken from one of the Geeky Medics websites. So they do have these useful sort of boxes that accumulate the information. So we've just decided that somebody's got abnormal LFTs. We've decided whether it's acute or chronic, and we've decided broadly whether it's a hepatic issue or a cholestatic issue. But what's actually driving the liver disease? And this comes down to a full non-invasive liver screen. And I don't know whether you guys, I'm sure you guys have ordered most of these things before, And if not, it's always worth thinking about it when you're seeing patients with abnormal liver function tests, because you'd be surprised at the number of referrals, again, we get from, other medical specialties. I feel a little bit more understanding of surgical specialties and stuff, because we often refer them lots of things that they probably think are quite straightforward. But actually, most of us should be able to just order these tests and think about these sorts of things in patients with abnormal LFTs. So this is answering the question of what is driving the abnormality. And this is a very straightforward and consistent list of extra blood tests, screening questions, and imaging modalities, particularly the ultrasound. I don't know if you can see that there, right? So ultrasounds are fabulous. If somebody has abnormal LFTs and they haven't had an ultrasound, order an ultrasound, whether it's overnight or not, because then it will just get plugged into the system, and it will mean in the morning people will have that done early before the ward round then come round and have to order it, and it doesn't get done for the next day. Also, you can normally, the way I do things when I go and see people who've got abnormal LFTs is I just like to make sure that whoever team is in charge of looking after that patient have at least within the last few months, because sometimes these patients are here for what seems like forever, right? But in the last few months had these basic blood tests performed. And the quickest way of doing that, because you might find that they've performed a few months ago, but if they've had daily or twice daily blood tests for a few months, it's difficult to search for. But if you just search under the immunology tab, the one that is least frequently done well, let's check for the immunology blood test. So that's the bit at the bottom here. These are the very least. There are a few that we can add on to this. So they, again, fall under the immunology side, where you're looking at the presence of auto-antibodies against different factors within the liver that can align with different liver disease. But I think if this has been done, it's basically screening for most things. And from a practice point of view, when you search under the ICE tab, non-invasive liver screen, it comes up with just the acute virology, I've noticed, which are these ones here, so the hepatitis blood tests. And it tends to say that do this first, and if they're normal, then do the rest. But I disagree with that. I'd say we need to do all of these from the off to prevent a delay in understanding what's going on. So this is a nice structural or structure of trying to understand what's driving abnormal LFTs and abnormal liver disease in patients with liver disease. So if you go to the BSG, they sort of have, so British Society of Gastroenterology, this is really their way of working up somebody with abnormal liver disease. And again, very much comes down to the individual, their demographics, what medications they're on, what comorbidities they may have. And then trying to box people into these different, so the yellow boxes, which again, you're looking at trying to differentiate between a predominantly hepatitic type picture, where you've got those increased transaminases, whether this is an issue of just isolated bilirubin rise, or whether the ALP, bilirubin, and gamma GT, this cholestatic type picture. And they also box this one that I'm highlighting just here, which is synthetic failure, which is also important to identify, of course. But essentially, don't worry too much about the bottom parts of, differentiating between NAFLD fibrosis and alcohol-related liver disease and stuff. I think the workup is the same. It's taking the history or looking at the patient demographics and their history, the pattern recognition of the LFTs into those yellow boxes. And then the next thing is, has somebody determined what is driving the liver disease, i.e. do they need a non-invasive liver screen, or do they need non-invasive livers to screen bloods adding to what to the non-invasive liver screen they have already had to complete it, to make sure there isn't anything else going on. And part of that is doing an ultrasound of the liver, which will give information about 3 things. And that's coming up next. But 3 things that are important from an ultrasound when you're looking at the ultrasound that has already been done. When you're looking at the report, it will tell you about the texture of the liver, which is always important because chronic liver disease is associated with this heterogeneous or nodular liver. That to us suggests that there's quite advanced cirrhosis and fibrosis. It's important to make sure that the radiographer or the sonographer who has reported the ultrasound has also commented on the bile ducts to make sure that there's no obvious blockage or stone. And the third thing is to make sure that they've commented on the portal vein. And what you're looking for there is the comment that there is antegrade portal vein flow within the portal vein, or antegrade blood flow. And what can happen is in certain instances you can get a blockage of the portal vein or a thrombus of the portal vein, and that can be driving the liver disease, causing the abnormal LFTs. And so, and I'd say on balance, it's the thing that is frequently not reported on the ultrasound is whether the portal vein is clear. And so if any of those 3 things, so that is the texture of the liver, the bile ducts, or the portal vein, aren't specifically mentioned on the ultrasound report, and the person has abnormal LFTs, then you can always ask the radiologist, the duty radiologist, to have a look at the images to see whether they can have a look and report on those 3 things. And if they can't, because sometimes either they haven't been checked or the images weren't of good enough quality to be able to see, then you have to do another. Then it's always worth repeating the ultrasound to make sure that that there isn't an abnormality in either of those 3 compartments on the ultrasound. And so I was thinking about sort of final practical points about LFTs, and I thought, like I said at the beginning, I think the most important thing is to identify what the pattern is. So that's what we were just talking about here in the yellow boxes, and determine whether this is acute or chronic. And certain things, whether that's the patient's history or, low platelets, might help determine whether the person's got chronic liver disease. Or you might look at the trend and you might just see that, for the last 6 months, they've had abnormal LFTs. So, this is a chronic thing. Also important to say that LFTs on ice don't include gamma GT or AST. But I think it's always important to add them because they give you a complete picture. I mean, really, you only need to add them if the ALT or the ALP are abnormal, but they help to complete that picture. If the bilirubin's high and it's not already been checked, check a split bilirubin level because it's going to give you further information about what's driving that high bilirubin level. And non-invasive liver screens are really important to do. They are poorly done across the board completely. And so if somebody's got abnormal LFTs, have a look to see whether they've had a full NILS screen. And if they haven't, add on a few extra NILS screens as appropriate. And ultrasound abdomen is a great way of working up somebody with abnormal LFTs. And I've just put a point there about the portal vein because more often than not, the portal vein isn't commented on. So those are the sort of things that I was thinking. You guys got any questions about any of that or any difficulties that you've had when interpreting LFTs or?
Hugo, can I just ask?
Yeah. Can't hear.
Oh, no.
Is that you, Helen?
Yeah. sorry, can you hear me?
Very faintly.
Oh, sorry.
Go for it. I'll listen in hard.
Sorry.
It's okay.
I was just going to ask, you know, when you're requesting a split bilirubin,
Yeah.
what does the value look like on ice? Does it say split bilirubin as a result?
Yeah, so indirect and direct. Okay. So indirect means unconjugated. So unconjugated is that part of the bilirubin before it's hit the liver. Okay. Direct is conjugated bilirubin, and that's the bit that has hit the liver and is already conjugated by the liver. Okay. Yeah. So it's indirect and direct. I'll be honest, like, people rarely do split bilirubin levels, but I think it's good practice because, and also it's another thing because more often than not, you know, having worked with hospital out of hours over the years, you know, you guys sometimes can be put in quite a difficult position where you're dropping in to review patients who are typically under the care of doctors during the day. And I think, you know, if you guys are forearmed with the knowledge, then it can really help to guide the patient management as well for the day team, because I'd hedge a bet that most medical teams won't know to check a split bilirubin level. But, you know, if it's suggested, you know, that a person's got hyperbilirubinemia and the day team have been scratching their head about it, you guys say, well, look, check the split bilirubin level, it might help. Then I think it's really useful to just to throw that suggestion out there to some of the other medical and surgical teams who are looking after the patients.
Thanks, Hugo. I was just going to ask as well if you can still hear me.
Yeah.
You know, when you're talking about AST and ALTs being raised in, say, sepsis, for example.
Yeah.
If they're really, really raised,
Yeah.
does that correlate with how unwell they are in particular?
It actually doesn't. What I found it does is it correlates really well. If it's due to blood pressure drop, it correlates really well with the blood pressure drop.
Okay.
And so what I do is, say recently I was asked to review a patient who had an ALT and AST in the thousands. So it was just over 1,000. Both of the markers was just over 1,000. And the referral had come in on the Monday and had come into me on the Monday, right? I picked it up on the Monday morning, but it had been referred on the Friday. Okay. And on the Friday, the blood test showed that the ALT and AST were over 1,000, about 1,100. And by the Monday, they'd rechecked them and they were about 500. Okay. Both markers, they just come down by themselves. And we see this a lot. And if you looked at the OBS chart on the Friday, they were really sick and they were hypotensive. Their systolic was like 80. Okay. And they'd had some treatment for sepsis, antibiotics and fluids. And on the Monday, you could see it was coming down as the blood pressure was stabilizing at around 110. And that part correlates really nicely. So if the AST, ALT rise is due to hypotension or sepsis, yes. When you fluid resuscitate them and you correct the hypotension, they come down nicely. It's a bit more tricky when it's illness from, say, paracetamol and stuff like that, because you don't see a clear comparison. And also some people tolerate it really well and then they just fall off the edge. So yeah.
And is it because in sepsis, is it because of the lack of perfusion?
Yeah, absolutely.
So that's why your hepatocytes die.
Yes, absolutely. So you get it's an ischemic hepatitis. Yeah. So when the blood pressure drops in that scenario, you know, the blood pressure dropped, you're not perfusing the liver in the same to the same degree. And much like, you know, the heart or the kidneys, you get like a pre-liver liver failure. It's temporary pre-liver failure. It's just we don't call it that. We call it an ischemic hepatitis. But if that were kidneys, it would be the same. If you're hypotensive, you get a pre-renal renal failure for exactly the same reason. There's a lack of perfusion to the kidneys that causes the issue. And the same with the heart. But yeah, so the liver's no different there.
Thank you. And just one last question.
Yeah, of course.
I think for me personally, on a weekend, especially when you've got somebody with deranged LFTs and you've not got a working diagnosis, or it's a little bit cloudy, it's how often to repeat the LFT.
Yeah.
For me. And it was just something that I know it's probably a difficult question to answer.
No, I think it's really fair. Yeah, it's really fair. It's actually, I think it's really fair because people will give you different answers. And I would say if you're concerned about the patient, if your gut says you're concerned about the patient, I'd do them daily over the weekend. Because come Monday, the people will thank you if they have a nice trend. Do you know what I mean? Even if it's going in the wrong direction, at least then we've got a nice trend, because liver function tests, unlike some things, they do change very quickly. And you do see quite nice stepwise changes that can happen in a 24-hour period. You know, typically I think the teaching about CRPs is that you're not classically supposed to do it every day because it can take X number of hours for CRPs to change and stuff. But actually, we still do CRPs every day in sick patients because it's nice to keep a track of them. And it's the same with the liver. Particularly patients that I worry about are, having said what I said about the AST and ALT, are patients with like really raised AST and ALT. So if it hits over 1,000, you want to be checking them every day. Bilirubin, if the bilirubin's going up and it's normally has a normal baseline, then that is, for me, alarm bells. And that can be going up, you know, anywhere above, I'm putting arbitrary numbers on this now, but anywhere above 100. Because the bilirubin, like I was saying, if it's up, it doesn't always mean that the person has biliary disease, as again the textbooks will tell you. If your liver isn't working right, it's not going to be able to deal with the bilirubin in the right way. So you also get a raised bilirubin level, okay, and that can cause that spike in bilirubin level as well. So for me, I think that's why I think bilirubin is probably the most important LFT to keep an eye on.
Thanks so much. It's been really helpful. Thank you.
No, that's all right. It's okay. Anybody else?
Just thinking about PT and coagulation. At what stage would you think we're going to chuck some vitamin K at this and try and see if that fixes it? Is there a cut-off that you'd look for, or is it an entire sort of clinical picture judgment?
Yeah, so if they're newly admitted and they haven't had it already. So I think after somebody's been on the wards for a few days, if it's been chronically elevated, more often than not, they've already tried it.
Okay.
But I'd say anybody who comes in who meets that sort of criteria, they've got an elevated PT and they have either got, they're either an alcoholic and thus we're thinking they might be nutritionally deplete, or they've got obstructive jaundice. I think those are the ones we said, weren't they? Those ones, I'd give them 10 milligrams IV vitamin K for 3 days, just to see if that will have an effect on the PT. Sometimes it drops it a little bit, but more often than not, with the people with chronic liver disease, it doesn't really touch the sides because it's being mainly driven by the fact that their liver doesn't work properly.
It's not going to cloud any diagnosis going forward. It's not going to sort of waters for anyone else.
No.
Thank you.
That's okay, mate.
Just a question about albumin. I noticed in some other trusts that they replace albumin a lot quicker than what we seem to do in our trust.
Yeah.
I don't know if is there a specific reason behind that, or?
So there's no evidence to replace the albumin if the albumin's low. The only evidence is if somebody has chronic liver disease and they have something else. So they have sepsis and you're treating them with IV antibiotics, or they're having a drain, so paracentesis, and they're draining their acidic fluid, we give albumin, or they have hepatorenal syndrome, we can give albumin then. But if an albumin's low, then we don't routinely give them albumin to try and replace the albumin. Okay. Is that okay?
Yeah, I was just a bit because like when you have patients that are sort of with the low albumin and the fluid's going into the wrong places when you're trying to fluid
so,
them and things.
So there's some muddy water there. So what happens is right. So if you've got, it kind of makes sense what you're saying, okay? And we debate this, and actually there's a split between the hepatology consultants as to their practice on this. But if your albumin's low, and we know that albumin creates oncotic pressure that keeps things inside the vasculature. And so if your albumin's low, then people sometimes are at increased risk of pooling fluid where we don't want the fluid in third spacing. And so we have to diurese them. And there is a train of thought that suggests that if you give them IV albumin alongside diuresis, you're kind of trying to pull the water in the right place that might aid with the diuresis and aid with shifting the fluid from a third space into the right space. There are studies that are ongoing at the moment as to like the way to do that best, but the data actually is quite conflicting about overall whether it is beneficial or not. Okay. But there are some people who do that. And for some cases, it's fair to say that for some cases, when you've got nothing else to sort of reach for, and some of these patients are very complicated and they've got loads of different things going on, sometimes as a last resort, people are given those sorts of treatments. But in terms of sort of routinely, we don't sort of trigger that in the same way we'd say the person needs frutamide. You wouldn't just go, yeah, and they need albumin as well. It's more of, that's the kind of thing that more comes out in the wash as, we see how the patient gets on with just the frutamide or without the frutamide, as it were.
Okay.
Yeah.
Thank you. Yeah, that's a good answer. Thank you.
That's okay.
Sorry, Hugo, can I ask a question?
Of course you can.
So sorry if this has already been covered. I had a bit of technical issues, but like with the chronic liver disease such as alcohol, etc.
Yeah.
Are you ever expecting their LFTs to improve, or is it like CKD where they sort of establish a baseline of dysfunction?
Yeah.
And then they get an AKI on CKD.
Yeah. No, that's a really good point. Yeah, exactly that. So when we're looking at patients in clinic who have chronic liver disease, you're looking at a deviation away from what their rough baseline is, and that being a marker of acute on chronic or decompensation of their compensated chronic liver disease. Yes. So some people just have chronically deranged LFTs and then present acutely with worsening LFTs. The caveat is that you can actually be cirrhotic and have normal LFTs. So whilst I said that LFTs like correlate really nicely with what's going on in the liver, there are you actually can have developed very advanced disease without an abnormality in your LFTs. But I think from a practical point of view, in patients, we don't tend to see that, because irrespective, the reason they're an inpatient is because they're unwell, and those patients have abnormal LFTs. You don't tend to have a situation where you're unwell from a liver point of view, but your LFTs are normal, right? But you're absolutely right in that we're looking at a deviation away from the baseline, whether that's within normal limits or whether that's the patient's normal baseline in the setting of chronic liver disease. Yeah.
Thank you. And when you're looking at the kind of, because obviously we don't, on ICE, you only sometimes get their current admission. You don't always get a full picture.
Yeah.
Is it just, again, I'm using renal function as a comparison, sorry. It's probably not relative, but is it just, so like we look at a mean creatinine.
Yeah.
is it useful to look at, if you can, look at the mean
Yeah.
of the bilirubin or the transaminases?
Exactly. And it tends to be, not always, but that like it's the bilirubin that you'd, in the setting of chronic liver disease, it's the bilirubin that you'd sort of take as your creatinine, as it were.
Right. Oh, that's really helpful. Thank you.
So you'd sort of like look at, in somebody with established, particularly, so we get a lot of alcoholics, right? We all know that, and they cause us all sorts of issues sometimes, and we're trying to work out what's going on with them. And I'd say the bilirubin's a really good marker of like, you know, looking at their trends, what's their normal bilirubin and what is it now, as opposed to the AST and ALT. I think my feeling is, and again, this is more anecdotal, but it's that, you know, when we're discussing these patients in the hepatology groups, we're discussing what their bilirubin is, right, as a marker of overall what's going on in their liver. We're not saying, well, the ALT was up a little bit. It's more like, if you want a global understanding of what's going on in the liver, it's in a person with chronic liver disease, what is their bilirubin? But it's also important to appreciate the other indices as well, of course.
That's great. Thank you, Hugo.
That's okay. Cool.
That's great. Thank you, Hugo, for today. Could you please send me the presentation and I'll email it out to the team?
Of course you can. Yeah, of course you can. Cool. That's all right, guys. Just give us a shout, and as well, if there's anything, just you can always email me, and if there's any other questions that you guys have or issues and stuff like that, because it's, you know, sort of what we're here for. So give us a shout. Okay.
Thank you.
Cool. I'll send that over now. Great.
Thank you.
Cheers, guys. Have a nice evening.
Thank you.
Cheers.
Thank you.
Bye-bye.
Very much.
Bye. Bye.
Guys, just before everybody goes, can I just sorry, I'm just going to start recording.